is going to be from Stephanie McLaughlin. She is one of our ID fellows who also has her clinic at the STI clinic at Harborview. So I'm excited to hear from you, Stephanie.
All right, thanks, Nina, for inviting me. Let me know if there are any technical issues as I go through. I'm gonna try to monitor the chat and respond to questions in real time, as well as try to make it a little interactive with the cases. So feel free to write things in the chat or speak up if you like. So I have no disclosures. I do need to acknowledge that a lot of these slides were modified from presentations that I do for the STD Prevention Training Center and the others do for the training center. So I tried to make them a little more focused on what might be relevant to you as residents, but a lot of the material is pulled from there. And this is what so I was a first-year fellow when I think the R3s were interns, so I probably look more like this, but now I look more like this. So if you see me in the halls, except I'll be wearing a mask, of course, feel free to ask me any questions. If you see me at Madison Clinic, I have Wednesday afternoon at Madison Clinic, and then as Nina mentioned, I also do one clinic a week at the Sexual Health Clinic, which is in NJB across the street. So see a lot of patients with sexually transmitted infections there. My research interest is sexually transmitted infections, particularly gonorrhea and STIs in women, as well as extragenital STIs in non-MSM populations, and then bacterial vaginosis in women's health as well. So if anyone has particular questions on that, feel free to ask me. And with that, I'm going to just introduce I should put a slide for objectives, but really I just want to build off of the last talk. So I was sitting in, hopefully not too intrusively, during the last talk just to see what was mentioned, particularly about the 2021 guidelines that were just released. So I may have some redundant slides in here, but I'm going to try to just sort of breeze through anything that's redundant and expand on points that you have questions about. So what you're going to do, we're going to launch a poll, and there are 10 mini cases. We will obviously not get through all of them. And there are a few that have multiple cases within them. So I'm going to have you vote for 2 different topics, and then I will just choose which ones have the highest number of votes, and we'll proceed from there. All right, so can we launch the first poll? While we're doing that, I will say another warning. I did not put any cautionary slides before I have any pictures of genitalia in my PowerPoint. So I guess I've become so accustomed to talking about this and seeing those. So if you are in a place with kiddos or a public place that you do not want to see that, I would just you know, be wary that I'm not giving any explicit warning in there. Okay, so if you want to read through these topics and vote for 2, I think we should give people just a little bit more time for this first poll, and it's going to be the same repeating topics. So think about what you would like to learn, and then we can maybe end it in just like another half a minute. How are we doing on responses? Do you think it would be a good time to close the poll? Okay.
Yeah.
All right. So it looks like people really want to hear about PrEP. So let's go to that first. Actually, let's see. I got to scroll down. Yeah. So let's do PrEP first, and then we'll poll again after we talk about that. Okay. So start with a case, but since we haven't, that's more kind of related to renal insufficiency, but since we haven't really talked about PrEP, I'm going to go over briefly just a general overview. So feel free to write your answers in the chat, and I will sort of try to tailor the response or the rest of this case accordingly. So baseline PrEP labs on a 45-year-old man, return of creatinine of 2.1, which is a creatinine clearance of 27. So what is the most appropriate next step? Do you prescribe Truvada, so the tried and true original PrEP? Do you prescribe FTC alone, or do you prescribe Descovy, which is newer and still branded version of PrEP, or do you not prescribe PrEP at all? So if you would like to write some things in the chat box, I'm going to come back to this case. So I'm just going to proceed to talk a little bit about background on PrEP, and then we'll come back to this question. So what is HIV PrEP? So we all probably know it's a strategy of taking antiretroviral medication to prevent HIV, and highly recommended for anyone at risk for HIV acquisition. I'll go over who those folks are. And mainly the point I want to make here is that anyone who has a bacterial STI, syphilis, gonorrhea, or chlamydia should have a PrEP discussion. And often we don't do this in non-MSM populations. So I think one of my takeaway points is to really consider talking about PrEP if you have women or other non-MSM populations that are positive for STIs and that you're treating. So there are two versions of PrEP, as I mentioned in the case. There's Truvada, which was approved in 2012. And then there was Descovy, which is TAF and M-tricytidine. And the important thing to think about for Descovy is a couple of things. It is for those with reduced renal function, but not for who have very impaired renal function. And the studies were not done in women with vaginas, or sorry, in people with vaginas. So those were having receptive vaginal intercourse, and we'll get into a little bit more about that. So the Discover trial was recent, and how Descovy PrEP was approved. And this was done because TAF has fewer renal and bone effects compared to tenofovir, although we generally think about Truvada as very safe for PrEP, unless someone has a pre-existing renal dysfunction or osteoporosis, as the bone effects are reversible, and the renal effects are usually seen more over time. So this was MSM in transgender women at high risk for HIV. And basically they saw that it was non-inferior to Truvada. There was less decrease in bone density, less renal injury, and that can be used and have marketed it as being able to be used in renal insufficiency. However, the renal insufficiency for which it is approved is a creatinine clearance of 30 and above. So indications for PrEP, I mentioned recent bacterial STI. There are a few others: HIV positive partner, multiple sex partner, sex without condoms. So sort of a lot of folks that fit into that category, those categories that I see. Kind of depends on where you have your primary care clinic. But I think you'll find if you take thorough histories on a lot of younger folks and even older folks, you will find a lot of folks that report these risk factors. So as I just was mentioning, it's important to take a sexual history. The other important thing to really think about before you start PrEP is asking about acute HIV symptoms, because we do suggest starting PrEP the day of. You don't really need to necessarily wait for creatinine to come back unless you know a person has renal dysfunction at baseline and you want to see what their current creatinine clearance is. So when you quick start people for PrEP same day, you want to make sure you rule out acute HIV because that theoretically can precipitate resistance if they actually have HIV that isn't caught on a point of care, an INSTI HIV test, which would not catch folks within the first kind of month of their HIV infection. So This does happen. I recently had a new patient at Madison with a recent HIV diagnosis who was unfortunately diagnosed with acute HIV when he was getting his PrEP at or when he was trying to start PrEP at Gay City. So definitely you want to ask about these acute HIV symptoms and don't prescribe PrEP if you feel like the person is at risk for acute HIV that day. After you've asked a sexual history, this is more important with folks, I think, non-MSM folks that are less familiar with PrEP. Even some MSM are not as well versed as some of the patients I see. But you want to make sure that you ask them these questions. Also ask when your last HIV test was, when was the last condom-less sex, in addition to those questions about acute HIV. The reason you want to ask about condom-less sex and who their partner was is you may need to start PEP instead of PrEP. And one of my other cases is about PEP, so we can talk about that if you guys like. But that is just basically giving the full set of HIV drugs to prevent HIV acquisition from usually a condom-less high-risk sexual encounter. And then after 28 days, you can transition the person to PrEP. So I have done this quite a bit. We do get referrals at Madison Clinic from folks seen in the ED for PEP for various reasons. And then, you know, I will counsel them about PrEP, particularly if I think they're higher risk, and try to transition them after 28 days. So when you wrap up the visit of prescribing PrEP, there are a couple options. You can give a 30-day supply, you can give a 90-day supply, but it's important to have every 3-month visits to test for HIV, to talk about adherence, as well as make sure that, to basically test for HIV, test for other STIs, and to talk about adherence, just to make sure things are going well. So again, we can prescribe Truvada, we can prescribe Descovy in theory. This is very, very much based on insurance. So I would say there's a lot of marketing with Descovy saying how it's, you know, better to prescribe off the bat, which is fine if your patients have private insurance. I don't think there's any harm to prescribing Descovy right off the bat, but a lot of times my patients at the sexual health clinic or at Madison are not able to get Descovy. So the ones that I think about are the ones with renal dysfunction, known osteoporosis, or other risk factors, and they often have to have prior approval. Also you should remind the patient that PrEP is really effective if you take it, particularly in those folks with a vagina, because PrEP drugs take a longer amount of time to reach an effective concentration in the vaginal tissue. And because of that, adherence is much more important, daily adherence in women or other folks with vaginas than it is in men. And in a little bit, just a few minutes, I'm going to talk about 211 PrEP just really briefly, but that is not something that you would want to do in anyone with a vagina having receptive, or anyone having receptive vaginal intercourse. We usually recommend condom use for 20 days in folks with a vagina, and condom use for receptive rectal sex or any insert of rectal sex for 7 days. If MSM or folks having rectal sex exclusively want to do 211 or want to, or you think they're not going to use condoms as a backup, you can have them take 2 doses in 1 day to reduce the amount of time that the drug levels will get to their effective levels in the rectal tissue. All right, so
Stephanie, I might just jump back. And yeah, there's a couple things in the chat. Maybe you were just about to bring this up.
I'm just gonna look at the chat. Sorry, I said I would be.
No, that's
I said I would be monitoring it, and then I was just like took off running. Okay. All right. So this was a bit of a trick question, and I have to say when this was a case from a Madison Clinic didactic, and I also chose Descovy because I didn't notice that creatinine clearance in this patient is below 30. So for folks with very impaired renal function, you cannot prescribe Descovy or Truvada. And then it's sort of a discussion of other ways to modify or reduce risk. So unfortunately, in someone with severely impaired renal function, you cannot prescribe Descovy. I will comment on or Truvada. So not great for this case. I'm looking at the chat. I will comment on on-demand PrEP. And then I have one slide on injectable cabotegravir. And I don't know if this will be just ID or general internal medicine able to give injectable cabotegravir. I have to say that, well, I'll tell you more about it when we get to that slide. Yes, and Descovy is not approved for those having receptive vaginal intercourse because the studies did not include this group. It was only shown to be non-inferior in MSM and transgender women, so not those folks with a vagina. So there are studies that are ongoing with those populations. All right. So here's just summarizing the creatinine clearance for which Truvada and Descovy are appropriate. And just reiterating that question that unfortunately that patient is not able to get PrEP. Second case, 35-year-old man with male partners only presents to clinic to ask for more information about PrEP. He has sex rarely and it's almost always planned in advance. He uses phone apps to find his partners. He's not sure he wants to take PrEP every day given his infrequent sex, but is concerned about HIV. So what would you suggest? So this is a question more about on-demand PrEP. And since someone already prompted me about this, I'm not going to have the answer question, but on-demand PrEP is only for those folks that are not having receptive vaginal intercourse. So usually MSM and other populations having anal intercourse. This is because drug levels get to better levels in the rectal tissue in a shorter period of time. So you take 2 pills 2 to 24 hours before sex, 1 pill after sex, if presuming sex that day, and 1 pill 48 hours. I should give a caveat that this is not recommended currently by the CDC, but we do it in the sexual health clinic on our PrEP side. And I do offer it to patients who really don't want to take daily PrEP. And there are some that really say, I know when I'm going to have sex and it's not that often, so I don't want to take a daily pill. So it is an option. You don't need to repeat the 2 pills if the most recent dose is 1 to 6 days prior. And if they're on vacation and this is the only time when they have a lot of sex, they can continue to take PrEP until 48 hours after the last sex and then stop it. So I have a couple more slides on on-demand PrEP. Just thinking about how far in advance sex is planned. So most people, as you might expect, don't plan sex, but there are some that do, and this is just sort of the spread from one piece of literature. So I think it's important to really talk about sexual practices generally with folks, and particularly before you're going to prescribe 2-on-1, because it is so important that they take it before planned intercourse. It's not going to work if they do not take it before, if they do not take those 2 pills before. So this is a slide. So actually, any questions about 2-on-1 before I briefly talk about injectable cabotegravir? I'm looking at the chat. Okay. So there was a study done with injectable cabotegravir, and it's given every 8 weeks. This was also a drug that we're trying to launch as an option for an HIV regimen in Madison Clinic. There are a lot of hurdles getting it and getting insurance to approve it, and just logistics, even for us in Madison. So I think it's going to be a while until it's, I guess I shouldn't assume, but I just imagine in GIN it might take a while longer in other clinics. But again, this was included large populations, MSM, transgendered women, and then some cisgendered women in sub-Saharan Africa, younger women, and the primary endpoint was HIV infection. And it was actually superior in women to Truvada. So probably because of adherence, although I would have to read the study in detail again to determine that. But as you might imagine, it's hard to take a pill every day and you don't have to think about this. So this is something that I think will be really great for PrEP on the horizon, but is not quite ready for prime time at Harborview yet. Any questions about, those slides? I have one more case, really quick for PrEP. All right, I can always come back. So just type in the chat box and I will review at the end of this case. So this is about pregnancy. So a 30-year-old woman presents to her 3-month PrEP follow-up in her first trimester of pregnancy. Her male partner is HIV and she does not know how often he takes his meds or if his viral load is undetectable. And what would you do about her PrEP? So if you would like to type in your answer, try to wake you up, make it a little more interactive. Would you continue her PrEP? What do you think? I'm watching, but I'm just gonna keep going. So generally, PrEP is safe in pregnancy. We use Truvada to treat pregnant women who have HIV a lot. There used to be more concern about fetal exposure to these regimens, and really my practice is that if they're at all at risk for HIV acquisition during the pregnancy, as they probably are because this person's on PrEP already, that I continue it. Obviously, it's shared decision making with the patient, but I would, particularly in this case, continue the patient's PrEP because we can't really rely on undetectable equals untransmissible because she doesn't really know the status of her partner. So of her partner's HIV treatment. So I would continue PrEP in this woman and just make sure you have a clear discussion with her. Follow up on this. She's having infrequent sex with her husband, asks if she can take 2-in-1 PrEP. She's also concerned with bone loss. She's heard about Descovy on TV. What do you tell her about those two things? This is just a review. Type something in the chat, guys. Yes. So no 2-in-1. What about Descovy? Yeah, no Descovy because she is a person with a vagina, so she really just has the option of Truvada, which she's already on. So great. All right, and then just a plug to remember to consider PrEP for anyone with bacterial STIs that you see. I think it's really important to think about this to prevent HIV acquisition because it works really well if we give it. All right, so any questions for PrEP? Okay, I can always go back. All right, let's launch the poll again and see what else people want to hear about. can probably get a shorter period of time. And then again, answer 2 so that I can get a good spread and talk about what people really want to talk about. Okay, I think we could probably close it. Okay, let's see. People want to talk about EPT and then PEP. Let's go to Expedited Partner Therapy next. All right, so we'll start with a case. A 19-year-old man with 2 regular male sex partners test positive for chlamydia and gonorrhea. We treat him in your office with ceftriaxone plus doxycycline, according to the 2021 guidelines, but he's worried that his regular sex partners will not come in for treatment. What can you do? And what would you give them? So go ahead and I'll ask you again to type in the chat your responses. See if you're awake, but I'm feeling people are getting tired with the talks this morning. So nobody wants to type, that's okay. Okay, all right, so there's kind of things to think about in this case. Is he as MSM, so 2015 guidelines are a little different than 2021 guidelines from the CDC about EPT. And I think previous lecturer mentioned that we now are more permissive about, or the CDC guidance language is more permissive about MSM. So used to be that it was not advised at all because of the concern for missing HIV and syphilis in these populations. We really wanted to bring in the partners of the male partners of men who have gonorrhea or chlamydia, or both in this case. But I think from a risk reduction standpoint, really gives clinicians a little bit more leeway in deciding whether they think if these partners are actually going to come in, even for MSM. So we really want to encourage people to present for treatment and testing for HIV and syphilis because we cannot give anything to their positive partner for those. But now in the guidance it says you can consider it an MSM. Legal in most states, including Washington, we do it at the sexual health clinic. So I would check. And it is sort of dependent on your clinic and who you're probably attending is, the supervising you. So if you want to know for sure if your clinic is able to do EPT, I would ask the director of the clinic. Nina, do you know if Roosevelt I know we do it at Madison, but I don't know if the GIM clinics or Roosevelt their policy is to do EPT. I mean, sometimes even though it's legal in the state, people don't necessarily want to do it.
Yeah, I remember having a discussion at Roosevelt or at the Women's Health Center about trying to get this done, but that patient's partner happened to have a doctor who they could easily just go to, so they ended up doing that instead. I've never encountered where like I would prescribe it for a partner.
Yeah. Yeah, and so I think you're legally covered to do it in Washington, but in the setting of training, it sort of depends on the policy of the clinic. So keep that in mind. So we want to treat partners within the past 60 days, or if this was a sort of remote like partner, if the patient is diagnosed with gonorrhea and chlamydia and hasn't had sex in the past 60 days, which honestly is very infrequent for me anyway to be that, you attempt to treat the most recent partner. And one thing I want you to know, which I didn't put in the slide deck, is because of COVID pressures, our disease intervention specialists at public health are not reaching out to partners with chlamydia. So, you should always counsel your patients about partner treatment and the fact that they should make sure that their partners do get treated, particularly before having sex with them again. But the Public Health Department will not reach out to people with chlamydia. They won't do any contact tracing because they just don't have the manpower. They used to do that. So they'll do that for gonorrhea. Particular priority is syphilis. And within HMC and UW generally, the labs will report. It is sort of mandated that the provider reports, but there's such a good system with the labs here that they will report to public health. And this is not true in clinics in the community. So if you go practice in the community after this, you'll need to keep that in mind. But things will get reported to public health, including chlamydia, but though they will not do investigations of those partners. So it's particularly important with chlamydia to talk about the patients notifying their partners or to do EPT with them, because with all the intervention specialists kind of diverted to COVID, and they just don't have the staff. If there are any questions about that, feel free to put it in the chat or interrupt me. So there have been changes, as I think was mentioned, and it's kind of everything just goes along with what you would do for treatment, right? So empiric treatment, PEP, EPT is really a version of what the new guidelines say for treatment. Obviously, you can't give ceftriaxone as EPT because they're not going to go home with a needle to inject their partner. So you do the alternative to fixing. It is a higher dose than it used to be. So it is 800 milligrams PO once. If you know that it's just gonorrhea, you can just prescribe that. If you know that it's chlamydia, you can just prescribe doxy. And if you can't rule out one or the other, not sure, you can prescribe both. This has been a big area of debate because it has doxycycline EPT hasn't really been studied, although it is recommended by the CDC now. So I think this is where, based on who the partners are, particularly if they're women of childbearing age, or you're concerned about other things regarding doxy, you can consider giving azithromycin. It's not what is advised now, but I think in my practice, I try to highlight on these slides in red what is me going off the cuff. This is also me going off the cuff, but I would consider the risks of doxy in the partners that you're treating. So particularly if it's a young woman and you don't know about contraception or pregnancy status. Information with that comes with EPT. So you should ask if they know about their partner's allergies. Again, the studies that have been done with EPT have shown that azithromycin and cefixime was safe and that there weren't many adverse events that came out of the dispensing of those drugs. But again, they have not yet studied doxy. So you should try and ask and also counsel as well as you can through the partner about the side effects of doxy, photosensitivity, GI symptoms, and particularly pregnancy in people who have partners that are have the capacity for childbearing. This is just showing the kind of the information that we have supporting EPT. And it is interesting to note that it really only prevents reinfection rates or has been shown to statistically reduce reinfection rates in gonorrhea, but we do extrapolate this to chlamydia and do EPT for chlamydia. So I sort of also use this piece of information in my head when I'm trying to think about risks of doxy EPT in certain partner populations. Okay, that was a little more nuanced. Any questions about that? You know, ideally, you should, if the partners can come in, you should bring them in and counsel them and treat them. So you may not be doing a lot of EPT, but it is good to think about as sort of a risk reduction strategy and folks who say their partners cannot come in. Okay, moving right along. Thanks to those few who have been answering my questions in the chat. All right, so let's see, what we have for time? We have about 10 more minutes, so let's launch the poll again. Again, choose your favorite two, and don't choose the ones that are purple on this slide because we've talked about them. If you're joining late. Okay. Oops, can you repost that? Sorry. You can post the results again. Thank you. Okay, so seems like people want to talk about PrEP in people of childbearing age or follow-up after STI diagnosis. So PrEP is sort of leading by a little bit. I may just, I think what I'm going to do is do the follow-up testing after positive STI diagnosis quickly, because I think there's some important takeaways, and then we can go over PrEP. Okay. Great. So, a 25-year-old woman treated for urogenital chlamydia 4 months ago presents to your clinic with an unrelated chief complaint, but you noticed that she was treated 4 months ago for chlamydia. Should you send STI testing? And would this be a test of cure or a retesting, rescreening situation? So I'm going to go over that bottom question, but hopefully you all would send STI testing. So I think I mentioned it perhaps, but in the PrEP talk section, but I know it was mentioned in the previous talk, that anyone who has a bacterial STI should be retested, not for failure concerns, but for reinfection concerns at 3 months. So I would retest this young woman who's coming into your clinic, and also assess her for kind of other risks for STIs, et cetera. So, and then we'll get into the test of cure and rescreening. So follow-up after gonorrhea and chlamydia. Just a reminder, folks need to abstain from sex after for 7 days. So that's 7 days after you give the single dose of ceftriaxone, or if you're going to go rogue and give a Zithro, 7 days after the Zithro, or at the end of their doxy treatment. So you should definitely let people know this, because if they may not be fully treated within those 7 days. And then you should also tell them, do not have sex with your partners until they're treated. And again, treat those exposed within the partners within the last 60 days, or the most recent partner if over 60 days. Partners also should be tested for HIV and syphilis. We talked about reporting infections to public health. And then what I really wanted to emphasize is the retesting at 3 months because of frequent reinfection. And again, these folks should have a discussion of PrEP as well. Not everyone who has a bacterial STI will want to take or need to take PrEP, but it should be a discussion. And then particularly, and I think this was mentioned briefly in the first talk, but I think it is a point of contention and question, and probably will come up if you have folks who have pharyngeal gonorrhea, or mostly for folks with pharyngeal gonorrhea, and then a note about rectal chlamydia test of cure after treatment with azithromycin, as it is less effective. So, and then again, I forgot to put this, but in pregnancy, as was mentioned in the first talk, there should be a test of cure done, just because the stakes are higher, particularly with azithromycin and chlamydia. So this test of cure recommendation for pharyngeal gonorrhea. So it used to be that test of cure was only recommended in the 2015 guidelines for when we used alternate regimens for pharyngeal gonorrhea to test at greater than 14 days. However, because of concerns, which I think I will put here, of failures in pharyngeal gonorrhea treatment, the CDC is now recommending that we do a test of cure for everyone who has gonorrhea in the pharynx. This is quite prevalent in men who have sex with men. And I don't think we're going to get to it today, but one of my other cases was talking about expanded recommendations in other populations. So in women who have risk factors, multiple partners, a new partner, transactional sex. So it's really a lot of leeway based on their sexual behavior. And then also in trans folks, we're screening based on sexual behavior. So I think that pharyngeal testing will expand and we will see more pharyngeal gonorrhea in more populations. This is actually an area of research for me. So lots of people have gonorrhea in their throat and it's almost always asymptomatic. So when we test and get a positive, it is harder to treat. And that is probably because unlike in vaginal tissue and rectal tissue, we don't get high levels of the antibiotics. So we are now advising ceftriaxone only, no alternative regimens for pharyngeal gonorrhea and retesting. The one thing I want to caveat is there's been a lot of discussion of sort of the downsides of this. There's a high rate of false positives at between 7 and 14 days. So we actually, if you are going to do this test of cure, advise that it's between 2 and 3 weeks. There is a balance between reinfection risk and false positive. But if you test at 7 days, you're going to get more false positives, and then it's hard to sort out whether those are failures. So the CDC says to test with NAT and culture if possible, which if you're not able to do a culture, you can always send folks to the sexual health clinic to do that because we do have that capacity. But I think probably at Harborview, they are able to do that. I'm not sure about at Roosevelt. And then the whole question about swab shortages has come up. So some places have chosen not to implement this guidance. This is just a slide showing sort of the disappearance of gonorrhea DNA over the course of, 1 to 2 weeks. So you can see that you can still, if you're within a week, you're still going to sometimes pick up DNA that is still evidence of infection being treated. So I would err on the side of longer if you choose to implement the test of cure, which is the CDC guidance. So again, I'm going a little bit off the book, but we are actually not doing this at the sexual health clinic because of various reasons, and only doing it if we have a concern for failure. But always discuss with whoever you are working with about, since you're training, about what they would prefer to do. And if folks want to adhere strictly to this test of cure, which I think is fine, I would advise doing it at 14 to 21 days. Okay. And the situation probably won't come up as much as azithromycin for rectal chlamydia. 21 days is when they suggest that you do a test of cure. So I say no sooner than 21 days. Very briefly, I know we're running out of time, but with syphilis, we did talk about when follow-up is happening. The one thing I want you to remember with syphilis is if folks are at high risk, you can test earlier than 3 months or 6 months in patients that are HIV negative, which mainly unless you're at Madison, you're probably seeing if the person is having a lot of sex and they are at risk. I would not call this a failure to treat unless they have not had a fourfold decrease in a year for primary, secondary, early syphilis, or 24 months for late latent syphilis. But I would keep an eye on a fourfold rise, which means that they've been reinfected and need retreatment, mostly for reinfection rather than failure. So you can test sooner, and I often do. And the practice at the sexual health clinic is to test at 3 months and then 1 month if reinfection is high, but not to call it sort of a failure, and to look at the whole picture of the case at 3 months and then 6 months and so on. So syphilis is a hard one. When we do our lectures for the prevention center, it's like a 2-hour lecture, so there's definitely a lot in syphilis to know about, but I think this is an important kind of point. So unfortunately, for those of you who wanted to talk about PrEP, I'm not going to have time, I'm sorry, but I'm happy to come back at any point, Nina, if you would like, or have space in the schedule. And I'm happy to take any, let me just go to my summary, take any questions. At the very end slide has my email, and then I think that Nina's going to post the slide deck. You can feel free to reach out to me. Happy to talk to you anytime. There are also opportunities for folks to come to the sexual health clinic and NGB if you want to get more experience with sexual health and STIs. So this is the new guidelines. So check these out if you have questions. Tried to highlight some of the changes, and the first presenter, who I'm sorry, I'm so bad with names, but I apologize. I know you're still on the call. It was a great overview of the changes. That was definitely wonderful preceding my talk, because I wasn't able to go over everything. So great job. Check these out. And again, she also mentioned the STD curriculum, which is great. This has not yet been updated, but will be soon be updated according to the 2021 guidelines. Just another plug for the sexual health clinic. So we do it was called the STD clinic for a while, but now it's branded more as a comprehensive sexual health clinic. We do insert IUDs. We do a lot of contraception counseling, some preventive health. I know most of you will be doing that for your patients. Things you might want to think about as if you have particularly challenging syphilis cases. We didn't talk about genitalium, but if folks have cases of that they're wondering about, because that's less common to encounter in primary care, but as a current hot topic in STIs. Really, people are able to walk in if they have symptoms. We prefer that they make appointments now, given COVID, if they can, but really it's very, very low cost or no cost to folks, and a good resource. And if you're interested in joining us, we are happy to have you too. And so here's my email. Sorry if I'm running slightly over, Nina, but here's my email. Any wrap-up questions? Sorry, Nina, I'm eating into the intern's time.
That's totally fine. Thank you so much, Stephanie. Yeah, the interns will just break off to go to their intern core conference, because that's on a separate Zoom link. But yeah, feel free to ask questions. I think we'll also just take a quick 5-minute break here. And then we'll come back for our senior only lecture with our advanced heart failure fellow.